Hello everyone, I am Dr. Harmeet Goel, Obs Gynae faculty, and today I am discussing the NEET PG recall March 2023, the gynecology part. These questions we have collected from the students who have given the exam, and exact all the options we are not able to collect, we are in the process of collecting. So whatever I have got from the students, I am just discussing that, and I can see the huge crowd of the students on the online sessions. So question number 1, a 30-year-old female came to gynae OPD with complaints of vaginal discharge with cervical erosion, no evidence of genital ulcer, no symptoms of lower abdominal pain. Which color kit you would advise her? Now let us see the question first. There is vaginal discharge, which is clearly written. Number 2, cervical erosion. And many of you are confused. Cervical erosion is just a normal finding when the squamous epithelium is replaced by columnar epithelium. That is what is called as cervical erosion, and most of the time we treat this by doing cryosurgery. And in this question, this is also written that there is no evidence of genital ulcer. So you can rule out the herpes. There is no proper symptom of the lower abdominal pain. It's just a vaginal discharge. So most of the time, a per speculum examination is done to check whether the discharge is from the vagina or it is coming from the cervix. So if you talk about the color kit, so color code, if it is vaginal discharge, then it should be the green color. For example, if there is any finding which is suggestive of cervicitis, then the color code of the kit will go to the gray color. Okay, so you can see the reproductive tract infection. This is a image which I have just downloaded, and there is a color code of the kits. Okay, and there's a clinical condition as well as the drug which is there in these kits. So if there is a urethral discharge or there is a cervical discharge, then we should be giving the gray kit which contains azithromycin and cefixime, because in cervicitis we are suspecting the gonorrhea infection or we are suspecting the chlamydia. For that we can collect the swab and we can collect the sample and we can do a saline microscopy. Just remember, chlamydia can only be detected on the cultures. Okay, so for the chlamydia infection, the drug of choice is azithromycin, and for gonorrhea infection it is cefixime. So clinically, if you're not able to differentiate, at least this kit is containing both the drugs and these are the broad spectrum antibiotics. Okay, so azithromycin 1 gram and cefixime 400 milligram. Now, if there is a vaginal discharge, then it is a green color kit which contains sacnidazole and fluconazole. Fluconazole is, like covering the candidal infection, and sacnidazole will be covering the trichomoniasis and bacterial vaginosis. Okay, so the drug for bacterial vaginosis and trichomoniasis is metronidazole group. So sacnidazole belongs to that group and it can be given stat, that is 2 gram. And fluconazole is antifungal. Okay, so vaginal discharge, basically we are treating all the 3 microorganisms, that is trichomoniasis, candida and bacterial vaginosis, which is caused by Gardnerella vaginalis, etc. Okay, rest, this part basically is been covered by the dermatologists because they are the venereal disease specialist. So from the gynae side, it is the cervicitis or vaginitis which mostly we see the cases. Now, next question is, a 15-year-old patient came with her mother with complaints of primary amenorrhea. On physical examination, it was revealed that breasts were present, no pubic hair. On transvaginal scan, uterus, fallopian tube, ovaries were not seen. Inguinal region, there is a swelling. What is the most probable diagnosis? So, from the students, different, like terminology or different, like question we are getting. So, I will try to explain. Okay. The options given were Turner syndrome, complete androgen insensitivity syndrome, Mullerian agenesis, hypergonadotropic hypogonadism. Okay. Number one, if in the question of primary amenorrhea, first of all, what do you understand by primary amenorrhea? Primary amenorrhea in a 13-year-old girl, if thelarche, pubarche, menarche all are absent, we call it as primary amenorrhea, and most likely it is Turner syndrome because ovaries are non-functioning. Now, another definition is in a 15-year-old girl, thelarche and pubarche are present, but there is no menarche. Okay, then also it is called as primary amenorrhea. Fine. So, if uterus, fallopian tube, ovaries were not seen in this case, okay, and in the physical examination, okay, in the inguinal region, if there is a swelling, then it goes in favor of androgen insensitivity syndrome, and this inguinal region, this undescended testis, you can visualize on getting an ultrasound done. And when you do per rectal examination after taking the consent, okay, you find uterus bulge is not present. So clinically also you can make a diagnosis of androgen insensitivity syndrome. It goes, not in favor of Mullerian agenesis, because in that case pubic hair will not be absent as ovaries are normally present in Mullerian agenesis. Turner syndrome, if in the question the breast was absent, height was less, uterus were hypoplastic, and ovaries is streak ovaries or streak gonads, then I will mark the answer as Turner syndrome. So those who have given the exam, they are the better judge what exactly was the statement of the question and what options were given. So many students are telling different question and another set of students are telling the different question. So basic difference in Mullerian agenesis. First of all, we go for a history, then we go for a general physical examination in a case of primary amenorrhea. So, in this case, the breast will be normal, axillary hair and pubic hair will be normal. This means ovaries are functioning normally. Then, on doing local examination, the external genitalia is female. External genitalia is female, and per rectal examination, uterus is absent. You can get a ultrasound done to check. In this case, uterus will be absent and ovaries are present. And karyotype, which is usually not our first choice, okay, the karyotype will come out to be 46XX. Now, androgen insensitivity syndrome, on looking at the patient, it is a female and the breast examination will be normal, but axillary pubic hair will be absent. And on doing the further general physical as well as local examination, there is bilateral inguinal hernia, and that bilateral inguinal hernia is undescended testis. Then on perrectal examination, the uterus will be absent. Okay. So external genitalia in this case is female. So this is basically defect in at the receptor level, where the testosterone is getting converted into dihydrotestosterone. If you talk about the karyotype, it is 46XY. Turner syndrome, first of all, the female will be short stature and there will be absent breast and shield-like chest, cubitus valgus deformity. All these features will be seen. In Turner, look-wise you can tell there is congenital webbing of neck, cubitus valgus deformity, hypoplasia of the breast. But important point is on ultrasound, uterus will be present which is hypoplastic and there will be streak ovaries or streak gonads. You can confirm it by karyotyping, which is 45XO. So, students, you are the better judge of the question. Ki what exactly was the question format? Accordingly will be the option. If I take it as a patient presented with primary amenorrhea and breasts were present and pubic hair were absent and entire internal genital organs of the female were absent, uterus, fallopian tube, ovaries were absent. In the inguinal region, the swelling is seen. Then in that case, it is androgen insensitivity syndrome. If in the question, the breasts were absent, totally absent, okay, but uterus is hypoplastic and ovaries are streaked, and patient is short stature, then your answer will be Turner syndrome. Hypergonadotropic hypogonadism, where it means that FSH and LH levels are high. But why the uterus, fallopian tube and ovaries will not be seen? Okay, so this does not match with this finding. So unless until we get the exact statement of the question, we are able to tell what is the exact answer. So I have told you the differential diagnosis in this case. Okay, so you can keep on writing what exactly the question format was, and if there is any doubts, further, so you can keep on posting in the chat box and we can again take up this question. Now, female with lower abdominal pain since 1 month, history of multiple sexual partners. So comparatively, the obs-gynae part was very much in the reach of the students and very good questions are being asked from this topic. So female with lower abdominal pain since 1 month, history of multiple sexual partners and mild intermenstrual bleeding. Intermenstrual bleeding is called as metrorrhagia. Metrorrhagia. And there is a scanty vaginal discharge and dysuria which subsided of its own. So whatever the infection was, it was self-limiting. So most likely organism in this case, is it a tuberculosis? Is it gonorrhea? Is it candida or is it herpes? From the history, okay, TB is almost ruled out in this case. Candida, you never get such a history in candida. So this is typically the history which favors, according to me, looking at the question which we have got from the students, goes in favor of gonorrhea infection. Okay, so many of the female are asymptomatic carriers and the gonorrhea organism can lie in the endocervix region. Okay, for this we can collect if there is any, like clinical presentation, there is a vaginal discharge, we can do the per speculum examination, we can take the swabs, we can do the gram staining, this is gram negative cocci, and we can do saline microscopy, we can do the gonorrhea cultures and all that, or we can just prescribe the treatment. Okay. So, in the gonorrhea, basically incubation period, is a 10 days, and asymptomatic carriers are common. There's a vaginal discharge, abdominal pain and the bleeding, and there is dysuria. So this is a classical presentation of the gonorrhea infection. Now, next question I have got it from the students is, a 16-year-old young female presented with primary amenorrhea with cyclical pain abdomen on physical examination. She has suprapubic bulges, and per rectal examination there was swelling along the whole length of vagina. What is the diagnosis? This is a very, very simple, straightforward question, that there is a case of primary amenorrhea, cyclical pain abdomen, there's a suprapubic bulge, and there's a swelling in the whole length of vagina, So clearly we can think this is an imperforate hymen. Why there is cyclical pain abdomen every month? Because ovulation is occurring and there is hormonal secretion from the ovary, and there is formation of endometrial lining, endometrial shedding, but there is defect at the outflow tract. So over the months, this menstrual blood will keep on collecting in the cervix, that is called as hematocolpos, in the uterus hematometra, and finally the female presents with suprapubic bulge, retention of urine and pain abdomen. And when you just take down the history, there is history of primary amenorrhea. So when you do the local examination, there is a bluish membrane which is bulging. So this is no other than imperforate hymen. Now next, 14-year-old girl's mother had a history of cervical cancer and she was operated for the same. That means the mother had cervical cancer and she has brought her 14-year-old daughter to the gynae OPD, because people come and they have a feeling that might be this is genetically transmitted, so my daughter will also have the cancer and all that. So what is the appropriate advice in this case you are going to give? Let us see the options which I have get from you people. What are the options that are being given to me is presence of BRCA gene BR, CA gene testing, B10 gene testing, HPV DNA testing, or HPV vaccine. Friends, this is a very, very simple and straightforward questions. The students which we have got in our Allen studio, and majority of them who have given the exam, they just marked it very, very correctly. It is no other than HPV vaccine. So for BRCA gene testing, there is history of breast cancer or there is history of ovarian cancer, then you can think of. But frankly speaking, I do not recommend, proper, counseling at such a young age. We can be just aware of it. There are two schools of thought. Let me not discuss it here. Okay. Now, in this case, it is simply the HPV vaccination which should be done. Now, about the HPV vaccination, it is Gardasil vaccine. Okay. There is Gardasil plain, which is a quadrivalent vaccine against HPV 6, 11, 16, 18. Okay. 6, 11 are known to cause, genital warts, and 16, 18 are known to cause the cancer cervix. Fine. So, in this case, there is another vaccine which is nonavalent vaccine, that is Gardasil 9, which is nonavalent vaccine. that is containing HPV 6, 11, 16, 18, 31, 33, 45, 58, 52. Okay. What is the ideal age for this vaccination is 11 to 12 years. WHO recommends this can be given as early as 9 years till 26 years, but FDA recommends it 9 to 45 years it can be given. So this age group is the ideal age group. There is no point in doing HPV DNA testing, which we are doing in the females who are married or who are sexually active, and we are doing along with pap smear. Okay, and HPV DNA testing, which is done every 5 years. Okay, starting from 30 years of female who is sexually active or who is married, and it is done till 60 to 65 years and then stop. So this is very, very clear that HPV vaccination should be given to this female, and it protects her from different cancers, genital tract cancers. HPV virus is a proven cause of cancer cervix, and it is also a risk factor for vaginal cancer and vulval cancer. Okay, this vaccination should also be given to the boys also, because the risk of anorectal cancer, oropharynx cancer, penile cancer, HPV is also a risk factor. Now, there's another question, which is a female undergoing treatment for infertility with IVF and injection HMG, human menopausal gonadotropin, which is an FSH injection, presented with history of vomiting, nausea, headache, and ultrasound shows the image. Friends, students, this is a very, very clear-cut question. HMG is an ovulation induction agent, and this is a very, very commonly used drug when we talk about IVF or we talk about ICSI. In this case, it is causing a side effect. It can cause a twin pregnancy, or it can hyperstimulate the ovaries and lead to a syndrome which is called as ovarian hyperstimulation syndrome. How this ultrasound image is different from the polycystic ovaries. In the polycystic ovaries, the cysts are arranged in the peripheries. So here you can see all over the cysts are arranged, and there's a clinical presentation like vomiting, nausea, headache, and there are grades of ovarian hyperstimulation syndrome. So none of else is been fitting here. This is very, very clear cut about ovarian hyperstimulation syndrome. And which is the drug that is causing most commonly? It is the HMG, because it is directly stimulating the ovaries. And first of all, if you get such a thing, always stop if there is any, like ovarian induction or stimulation drug has been going on. So first of all, just stop it. Okay. Now, next question. Female presented in the gynae OPD gives a history of multiple sexual partners, diagnosed with cervical cancer, and that was extending to the left parametrium with lateral pelvic wall involvement. What is the treatment option? Okay. Clearly, if there is a parametrium involvement and that growth is going to the lateral pelvic wall from the cervix, suppose this is the uterus, okay, from the cervix, okay, if that is extending to the lateral pelvic wall, so this is already a stage 3B. And in the advanced cancers, what is the treatment option that you give to your patients? So the options given it here was radiotherapy, chemotherapy, surgery, and chemo radiation. So it is clear cut, your answer is concurrent chemo radiation. And what is a radiosensitizer drug is cisplatin. Now, let us just quickly see the staging part. In stage 1, it is strictly confined to the cervix. So, these are stage 1A and A2. For 1B, there are 3 parts, B1, B2 and B3. 1B3, why I am showing this? This is tumor size more, and whenever the tumor size is more, then always it is better to go for chemoradiation. Although I am not denying that we cannot go for surgery, but results are better with chemoradiation because the tumor size is more than 4 centimeters. Now, stage 2, when the cervix cancer has invaded the uterus. 2A, when it is limited to the upper 2/3 of vagina, and it is also A1 and A2. Stage 2B, when it is involving the parametrium but not gone onto the pelvic wall. Whenever the tumor is extending to the lower 1/3 of vagina or to the pelvic wall, or it is involving the kidneys, already it has gone into stage 3. So from the history, it appears as stage 3. Okay. So if it is extending to the pelvic wall, it is already stage 3B. Okay. Now, stage wise, if we see for stage 1, A1, A2, B1, B2 and 2A1, it is surgery, and 1B3 and 2A2, because the size is more than 4 centimeters. So it is, the results are much better with concurrent chemoradiation, because chemoradiation will damage the tumor. Okay. Much better than the surgery. So in advanced stages, our question, it is fitting into stage 3. So already the answer is concurrent chemo radiation. Now, what is a radiosensitizer drug for cancer cervix? It is cisplatin. Now, another important question, let us take up. A 22-year-old female brought by her mother-in-law to gynae OPD with complaints of inability to conceive for 6 months, and she's cohabiting with her husband without using any contraception. What will be your management? This is a very simple and straightforward question. Okay, age of the female is young, number 1. Number 2, the definition of infertility says inability of a couple to achieve pregnancy even after 1 year of regular and unprotected coitus. Okay, so she's just been 6 months only married. So in this case, we will not start the infertility investigation. So the options are reassurance for 6 months, semen analysis, ovulation studies, and I think HSG. Okay, so I am in favor of reassurance. Give her a benefit of 6 months. She will conceive spontaneously, and if she is not able to conceive, then we will look at the case and we can take down the detailed history, do the examination part and start doing the investigations of infertility, but not in this case. There's another question. A young female came to gynae OPD with complaints of pain on standing and walking. She gave the history of multiple sexual partners, and image given was something like this. And since you have given the exam, so you are a better judge, you can tell us what exactly it was. If it is a history like this, and like there is a history of multiple sexual partners as well, this looks and appears to me as Bartholin abscess, and the management is incision and drainage. I hope these explanations are clear to you, and sincerely I hope that obs gynae part all of you must have done very well, because questions comparatively not were very difficult. So all the best for the result, and it's thumbs up from my side that hope you get a good rank and you get the subject of your own interest or own choice. All the best.